So welcome back. I hope everybody had a good lunch and is ready for us moving into phase 3 here. And so this afternoon we're going to shift to a lot of the questions that have come up already, which have to do with the treatment end of things. And I want to be clear on why I went through these two cases of kids who don't have autism this morning. The reason is because sometimes I think it really helps to understand what is not autism, to make us understand better what the issues are when you see these symptoms in the context of autism. Because I've already said that one of the things that happens is that symptoms get entangled and they get changed. And so to some degree, seeing them outside of that context is helpful. At the same time, everybody's here for an autism talk, and so we are now going to be talking about children who do have an autism spectrum disorder, and as well as having different behavioral and mental health issues and how one could approach them. So we're going to go back to our comorbidity algorithm, and in terms of kind of declarations of bias, this is probably the biggest bias I have, which is that I believe that if a child with a developmental disability, including autism, has a psychiatric disorder, you have to ask a few questions. One is it developmentally pathologic? Is it treatable? And to avoid reactive psychopharmacology, meaning avoiding waiting until things are too bad. Other than that, the basic approach to treating psychiatric disorders in autism is not that much different structurally than it would be for a child without an autism spectrum disorder. We've already looked at this information a little bit earlier today about the impact of psychiatric phenomena on development and ability of a child to be able to utilize developmental interventions, whether it's ABA or speech and language therapy and so forth. What I tend to think about in developmentally disabled kids with mental health issues is that the importance of treatment is directly related to the impact of these disorders on the development. So it's a little bit different than what we would see in a neurotypical kid, in the sense that kids with neurotypical profiles, it's the ADHD per se that is causing the difficulties that come to bring the child into the office. With a kid with a developmental disability, sometimes it's the developmental regression or change that actually brings the kid into the office. The other thing that I think as a declaration of bias is my attitude towards medications. And I think that one of the things that I have become more comfortable talking about is that I think medications are a key piece to treating kids with autism spectrum disorders across the lifespan. They are one of the tools in the toolbox, and I think we need to change our attitudes towards medication, as opposed to being something that we need to avoid, as opposed to something that we can utilize in a functional and helpful way. So lots of times people will say, or parents will say, "Doctor, does he need to have the medication?" And I say, we're not going to talk about need, right? It's not a question of need. We didn't have this medication 20 years ago, so how could you talk about need then? We have the ability now with certain tools, certain technological tools called medications, to be able to alter certain things. And the question now is, can we improve things above the current trajectory? So it's not a question of need as much as how much will it help? Okay, so we spent the morning talking about the developmental approach to things and the fact that we need to pay attention to developmental trajectory, not only in terms of the changes that evolve with autism, but also in terms of cognitive development. And now we're going to talk about how we go to the next level, the psychiatric assessment. And we're going to again do this through use of a couple of cases. Case number 1 is another 11-year-old boy who has been referred. This boy doesn't have a name. He's just boy. Yeah, I got CJ, DJ. Oh, you haven't met DJ yet. I don't think DJ yet. I have BJ, CJ, and DJ, and the EJ just didn't work. So he ended up being boy. Anyway, boy was diagnosed with autism and a global developmental delay in preschool. He received fairly well-designed and faithfully delivered intensive ABA for several years. He's now in a mainstream classroom, and he has full-time aid support there. Up until grade 6, which is this year, he's actually been relatively easy to manage from a behavioral perspective, but now there's increasing oppositionality, he's frustrated, he's getting dysregulated, even to the point of aggressive behaviors. We've heard this story before. The family feels like he's regressed generally. Again, we've heard this story before, and has fallen further and further behind his peers over the last couple of years. At the same time, when you actually look at it, his baseline functioning has always been pretty low, particularly out of structured supervised therapy settings. So in generalized settings, his demonstration of skills has not been as consistent. Thus, he does have some verbal language and even some short phrases, but this is pretty prompt dependent and pretty inconsistent in a general setting. He continues to work academically at a pre-academic level, so he's just still kind of working on letter recognition and number recognition and output, maybe a few words like his name that he can recognize and write, but not very much more beyond that. Again, when the interventionists are interviewed, they say that he can actually do a lot of reading and can identify complete words, but it seems that some of this may require a good deal of scaffolding and might be a little bit overlearned. Adaptively, in terms of life skills, daily living skills, he's functioning more like a preschooler, although he's now toilet trained. This happened when he was in grade 1. Yay! And he can put on and take off clothing with a little bit of direction. He can use a spoon. He's starting to learn to use a fork. He still needs a lot of supervision with general hygiene to make sure he brushes his teeth properly and wipes his butt properly and all those sorts of lovely things. In terms of his interests, he tends to gravitate to a preschool level, so he's still interested in Dora and whatever the current version of that is. So although he's still theoretically, quote-unquote, integrated in his grade 6 classroom, his work is pretty modified. It hasn't really changed much in the last few years. It's getting kind of repetitive. When you ask the teachers about what they're teaching, it's the same kind of curriculum, same stuff that they've been doing for several years. And he's kind of bored with it. Yeah? He's kind of like, I've been putting things in shapes for the last 4 years, and I never thought I understood what we were doing it the first time. Why are we doing it now? And he's getting more resistant towards it, more oppositional about it. Sometimes he even gets a little agitated with regards to that. As a result, the school is struggling to figure out what to do, how to teach him, and the family have a somewhat different perspective on what this kid's abilities are, and they are having a great deal of difficulty agreeing on appropriate targets and goals in his IEP. So the parents and his community team argue that this is a very capable kid in the right circumstances who can converse, can read, although they acknowledge some of the writing perhaps has lagged. The school really doesn't see the same thing, and they really see him more at a K grade 1 level perhaps. But as a result of this tension and this lack of agreement, really there isn't any clear measurable goals being set up year to year, and hence a lot of the repetition. Well, all we know about this kid in terms of assessment is that he was diagnosed when he was 3 with autism, and at that time they did a version of a cognitive measure called the Bailey, on which he had a score of 65, which would have put him around what we would now think about a mild ID, although the Bailey as a tool at age of 3 is not a very good predictive tool, so we don't really know. His language at the age of 3 was about at half of his chronological age as well, so around the same level. So he was showing some significant delays at the age of 3, although the focus was on the fact that he had diagnosis of autism, and really no one paid attention to this GDD, Global Developmental Delay component, and he hasn't had any standardized retesting since then. And this brings us back, I think, to some degree to wanting to review that we need to be paying attention to these things. We need to be paying attention to developmental trajectory, and before you even get to the next step with this kid, what you really need to know is, are we dealing with a kid that we have an appropriate understanding of their cognitive abilities or not? And issues in terms of this regression. So the community team has been working with him for the last 5 years, basically ever since he got into school. It remains pretty quote-unquote ABA focused. BIs are using discrete trials to teach expressive and receptive language, some academic skills, occasionally some adaptive skills. That was actually the key to getting him toilet trained. He had some speech and language therapy when he was in preschool, but as often happens, by the time he got into kindergarten, access to speech and language therapy diminished in the public forum, and most of the family's resources in terms of autism intervention has been directed towards ABA. So there's a speech path at school that does some consultation with the school team, but really hasn't had any direct input or evaluation. His spontaneous verbal language in the classroom is maybe a handful of words, a lot of nouns, maybe a few verbs, and some chunk phrases, but really not a lot of flexible phrase use. And he's been at this level really for at least 3 or 4 years, really hasn't changed a great deal. There was a brief attempt to introduce what's called an augmentative communication system, a PEC system. An augmentative communication essentially means using a means other than voice, verbally, to communicate. And that can be sign language, it can be pictures, it can be technological. And so there was an attempt to use a PEC system at one point, but this was a few years ago. He just basically chewed them all up or threw them away, and it didn't go very far, so they got dropped. And then a couple of years later, someone bought a tablet and put Proloquo on there, and he threw it across the room and got broken, and they didn't want to get it fixed. So nothing's happened more with that. Parents report that there have been challenging behaviors at home and in therapy, but they really have been managed by lots of tangible reinforcers, rewards, right? Lots of this positive reinforcement for positive behavior and tangible reinforcers for good behaviors. And in the context of therapy, and to some degree at home, these tangible reinforcers can be effective. The problem is translating those to the broader world. And the school, for example, is not particularly interested in introducing a whole system of tangible reinforcers. They're not comfortable with giving candy or whatever it happens to be. And so there's some tension around that as well. As he's gotten larger as well, although his behaviors may not have changed, he's louder. And he's also more disruptive because he's bigger. And it's getting harder and harder just to have him integrated in the classroom, or have him in the classroom, much less integrated. And so in the last year, there are a number of incidents where he is starting to get intrusive with others, and there's challenges between him and the other kids, and again, some behavioral issues start to emerge. When you probe, you find out that the parents have had this behavioral intervention team together for quite a while, but when you ask them what they've been doing, we get the information around working on discrete trials, around learned skills development, and really there hasn't been any attempt to teach parents using a positive behavioral support modality. And this comes to, I think, one of the first critical steps for anybody working with children with autism in this area, even if you don't do any of these things, is you need to know what they are. And you need to know how they must evolve and reflect the child's needs. I think one of the biggest problems I see with kids growing up is they outgrow an intervention, and people stay with it for far too long beyond the time that it's still useful. And we, again, in our field, we have terminology that tends to group things together and facilitate us communicating about it, but it really sometimes doesn't reveal what's really going on. So, for example, this 11-year-old boy comes into my office, and I say, well, do you have a behavior consultant? Yes, we have an ABA consultant. And you could stop right there and say, well, they have a behaviorist. Now the kid's still having maladaptive behaviors. I guess all we can do is medication. Or you can take it to the next step and say, well, let's understand what you mean by behavioral intervention, right? What is it that the goals are of your intervention, and what are the strategies using? Operant conditioning, which is the core of behavioral intervention across the board, has been revised and changed for specific goals, whether it's to acquire skills in ABA, whether it's to reduce maladaptive behaviors and positive behavioral support, similar sort of orientation, but the goals are different. So one of the first things is really to be clear about, well, what are you doing in terms of behavioral intervention? The other is to keep pace with the other developmental interventions. So I mentioned how this is the boy who used to have a PEC, or the PEC system had been introduced, or a tablet communication had been introduced, but it didn't work when he was 5 or 6 or 7 years of age, and it's been not pursued, again, because it didn't work when he was 5 or 6 or 7 years of age. Again, I think a lot of times kids have to be ready. And so that same kid at 5 or 6, if you introduce that communication system to him now at 9 or 10 or 11, it can be effective. And so paying attention to that is important. With a higher functioning kid, language demands change as well. And so core language is less of an issue at that point with adolescent kids who are higher functioning, but that's when the social communication, the conversational abilities start to become more relevant. So again, changing the orientation, even if this kid has speech and language therapy, working on speech sounds at 11 when they have social communication problems may not be the best use of this kid's time and the family's money. Educational, the goodness of fit. I think it can go either way. You can have kids where we think that they're capable of more and we aim too low and the kid is really bored. And you can have kids who are capable of less and we aim too high and we've lost the kid. Either way, there's lack of fit. And you need to have whatever you're teaching them at least, close, a little bit higher, but pretty close to where the kid is. And you're only going to know that if you have some data to support what you're saying. And then there's a host of the other developmentals, the motor issues, the sensory issues, the social abilities. And the social abilities is to some degree reflective of the changes in demands, not so much the changes in the boy, as much as the fact that everybody else is doing this now. And again, parents, teachers see kids in age blocks, so if every other 6-year-old is going to the sock hop, that is an appropriate social goal for this boy in their mind. The accumulation of stress, and this comes in, and we're not going to spend a lot of time, but the impact of this on family functioning at various points. There are these different kind of cross-sectional, or the transition points in these kids' lives where I think we were talking a bit about this at lunch, where I hear from parents is that, you kind of think, okay, we've got it all figured out, I know what's going to happen, we're going to do this, and then we'll get there, and then it'll be done. And you get there, and then the doctor says, and there's a new thing. And say, okay, well, fine, okay, we'll deal with this, we'll address this, and then that'll be all I have to do. And then you get to the next point, and then something else happens. And that cumulative kind of barrage of more and more and more at various points. Middle school is a typical one. You see families really starting to come to terms with the fact that they're now dealing with a problem that is not in a young child, it's in an older child. You're starting to deal with the fact that when they're in high school, that you're now dealing with someone who's going to be transitioning to into adult life. Okay, back to our boy. So this boy has some of our favorite neuropsychiatric symptoms that we like to talk about. He has some motor tics and some verbal tics. He squints, he throat clears, and he picks. Picking is a bit of a ticky-like behavior. They come and go, really never been an issue, more than an annoyance. When you ask him about anxiety, because this is the next step we're looking at, this is the mental health piece, obviously, what you get is just kind of immature fears. The sorts of fears that typically 5, 6, 4-year-old kids would have. Dark, a little bit of separation stuff. No broader anxiety like we were talking about with BJ earlier today, where he's worried about things and very, very shy. He's always had a lot of ritualistic behaviors, and this goes back to your point, Miriam, in terms of what do we do with this? So this is a kid who's always liked to order and arrange. But, as you said earlier, there's evolution to this. So when he was very little, it was just the DVD cases. Right? He got a little bit more able. It became placement of his items in his bedroom, had to be in a certain place. It gets even more elaborate in terms of how the chairs are arranged in the kitchen at a certain point. But the form, the phenomenology, remains somewhat the same, but evolves. He also tends to be very particular around kind of sequences of events, particularly things that he's done a lot. When he gets stressed, quote unquote, some of these compulsive behaviors, quote unquote, increase. He starts to become more one of these kids who wants to line things up and make sure that all the chairs are aligned in a certain way. And this has led to a question, but maybe this kid has OCD. He's followed by a general pediatrician who thinks he might have ADHD as well, wonders about that, but there was a trial of a stimulant medication in kindergarten, and it just had so many side effects associated with it that they abandoned it and it hasn't been tried again. Again, though, he has some behavioral issues, so the pediatrician looks at the American Pediatric Association guidelines and says, well, the only approved medication for autism is risperidone and Abilify, 2 second-generation antipsychotics, and we should start one on him. And he gains only 15 pounds. Okay. So some of these questions that come out of this case, we've already kind of talked about. Is this a real regression of autism? Who says yes? I won't kick you out. Probably not. How do we disentangle it? We disentangle this by looking at the developmental profile, the trajectory, understanding where he's at right now, and looking at the current functional issues. There clearly is a role here for multidisciplinary input in terms of understanding the psychiatric and behavioral piece, because until we understand this kid's cognitive development and his language capacity, for example, it's going to be really hard to know what to do in terms of how to interpret the symptoms that he has. And finally, you've heard me talk about SGAs, second-generation antipsychotics, all morning. We're finally going to talk a little bit more in detail. When do you use risperidone? When do you use Abilify? When do you use quetiapine or olanzapine or all those medications, which have become very, very popular in treatment of kids with autism? And this is my other bias. I'm not a fan.